is not a surgeon, he is a rheumatologist. A rheumatologist is somebody who takes internal medicine training and then takes a subspecialty in rheumatology. And the business of osteoporosis has been, it's a turf issue. Endocrinologists think they know a lot about it. General internists like me think they know something about it. The reality is that the people who know most about osteoporosis are rheumatologists. And I'm going to leave it off to Dr. Shuka to talk to you all about it. There are treatments, there are new treatments, there are old treatments. It's a very, very active field of medicine. So,
thank you. Thank you, Dr. Bright, for inviting me. I'm delighted to be here. So the topic is osteoporosis, as Dr. Bright mentioned. So I'm the rheumatologist. I practice in Fresh Meadows, 16303 with orthopedics folks. So, so we'll start with osteoporosis. So osteoporosis is, it's basically weak bones. So the image here on the upper left side is a normal bone. You can see, let me point this. So you can see how dense the bone is, and this cartoon here is showing how the bone has become more porous, which we call osteoporotic bone. So it's a disease where you lose bone mass and the bone becomes weak, and then you have increased risk of fractures. There is a condition we call fragility fractures, which happens in patients who have osteoporosis or who have high risk of osteoporosis. So what we call fragility fracture is when patients have a fracture from falling from a standing height or very low impact, just missing a step and having a fractured bone, or even no trauma at all, just violent cough and the people break their ribs. So those are the things which we do consider in patients who never had osteoporosis scan done or checked. Common sites of fractures are hips, spine, and the wrist. So who gets osteoporosis? So the stats show 54 million Americans have osteoporosis and low bone mass. 1 in 2 women have osteoporosis after age of 50, and 1 in 4 men after age of 50 have osteoporosis. It's more common in advanced age, and osteoporosis, although more common in females, 20% of men also gets osteoporosis. So there is a stat by 2020, by next year, approximately 12.3 million individuals in the US after age of 50 will have osteoporosis. So the most common signs of osteoporosis in itself, it does not cause any pain. You only feel the pain if you have a fracture. So it's clinically silent disease. So when you do have fracture in the vertebra and the spinal cord, you can eventually lose height. People start noticing that they have more height loss, more than 1.5 inches considered significant height loss. They have a more hunched or stooped appearance, and people complained of back pain. That's another sign of a fracture in the spine, and they have high tendency to fracture bones if they have advanced osteoporosis. So what a woman needs to know about osteoporosis: so all women who go through menopause have a high risk of bone loss, and within 5 to 7 years of post-menopause, they lose about 20% of their bone density. So this is due to deficiency of estrogen. There are some treatments in patients, females with breast cancers. The medications called aromatase inhibitors. So some of the patients are on these medications. They also increase the risk of osteoporosis. And 80%, as I said, so total population in America are females with osteoporosis. So men, 20% of the group. So men get ignored because most of the guidelines to treat or screen osteoporosis are done on females. Most of the literature most of the studies, including the treatments, are approved for females. So there are estimated 8 million men in US who have osteoporosis. Older men do get they have worse outcomes than females who get the same fracture. This has been related to advanced age and also certain comorbidities like diabetes or hypertension. And there are some male-only conditions where men with low testosterone gets increased risk of bone loss. And there are treatments actually for prostate cancer where we use the medication to decrease the androgen, which is the male hormone, that also increases the risk of osteoporosis. And starting about age 65, actually men and women have the same rate of bone loss. So how can we prevent osteoporosis? So the things which we can do from your part is monitoring diet and lifestyle, exercise, and prevention of falls. So the body by 20 years of age, the body produces more bone as compared to bone loss. After 30 years of age, body starts to lose bone. So it all depends upon how much a reserve you have. So eating foods with calcium that helps bone building, such as milk, yogurt, and green leafy vegetables. Total recommendation of calcium intake daily is 1200 milligram daily. This is for postmenopausal females and patients who have high risk of fractures. And vitamin D, which is also an essential element for bone building. It's in fortified milk with vitamin D. And fish, the recommended dose is 800 international units daily. And if you cannot take via natural diet way, there are pills which your doctors can recommend. And if you are smoking or if you have excessive alcohol consumption, they also put you at higher risk of bone loss. So this is a little, so on the left side, there are food and drinks that contain calcium, so milk, yogurt, so there is amount in milligrams, so milk has 300 milligrams, yogurt has 250, and so on and so forth. So orange juice, tofu, cheese, so these are good dairy products that have enough calcium. There's an ice cream there, so also 100 milligram of calcium in it. And these are the vitamin D sources. So sunlight is the natural way of getting vitamin D, but you have to sit in the sun for an hour to get enough vitamin D, which everybody is deficient. So the other sources are cod liver oil, so it contains 440 international units. Salmon, so 400 international units. Again, the recommended dose from National Osteoporosis Foundation is 800 international units a day. So the fish are good source of vitamin D, and then milk, eggs, and mushrooms also.
Raw milk, is that unpasteurized milk? Is that?
Yeah, so unpasteurized milk actually has a vitamin D, but when you get pasteurized, it doesn't have. So most of the milk we get is fortified with they add vitamin D in top.
Excuse me, what about the people who are lactose intolerant? What do you recommend?
Yeah, so that's where the medication, the calcium pills. So the recommended dose is 1200 milligram a daily dose. Yeah. I mean, there is some sources of calcium in almond milk. So there's some of the, but the amount is, as you can see, it's 300 versus 17 almonds. So not enough. So this is very important, the prevention of falls. So how can we prevent falls? So remove the rugs which are loose. Keep the rugs that have no slip backing at home. Tuck away any loose electrical cords. So this is also a recipe for disaster. Light all the walkways well. Install a night light. Watch out for slippery floors. When it snows or ice, you have to be careful. Wear sturdy, comfortable shoes that have rubber soles so that you don't slip. If you have vision problems, we do recommend checking your eyes. And ask your doctor if you are on any medication that can cause lightheadedness or dizziness that can further increase your risk of falling. So exercises, the recommendation is 30 minutes 3 times a week. The recommendation are weight-bearing exercise, so like walking, even dancing. So these are where you stimulate your bones. Swimming is not considered as a weight-bearing exercise. And then muscle strengthening exercise, so lifting weights, calisthenics, and exercise bands. So we do recommend in patients who have a problem with the gaits, so physical therapy and occupational therapy, we refer our patients for these sort of exercises and balance exercises as well. So there are studies, prospective studies done on patients who were enrolled in exercise, and they saw there was a reduction in the hip fracture in older women. There was not much reduction in the spine, the vertebral fractures, but they amounted that the study group was small. But there is definitely benefit of exercises as well as balance exercises. So you're never too young or too old to protect your bones. So now is the time for action. So how do we screen or test osteoporosis? As I mentioned, it's not going to give you any symptoms. So whenever I get a referred patient for osteoporosis treatment, they always complain about joint pains. I have pain here, but I tell them this is arthritis pain, that you don't have a pain because of osteoporosis. This is because we tested you with this. This is a DEXA scan, which is a bone mineral density scan. So this is a sort of X-ray. So this is how we get to know a person who has osteoporosis. So who gets this screening is, so this is again very well defined for females. So all women who are 65 years of age and older, postmenopausal females, they get, so the general recommendation is for testing those females. Any patient who is younger than 65, so we look into any clinical risk factors. I'll come up, there's a next slide for clinical risk factors I'll discuss. And men, there is again, the guidelines are not well defined. So what we agree on consensus is men who are 70 years and above, we do recommend a bone density scan, or they have any clinical risk factors. I'll come to that. So this is World Health Organization classification of osteoporosis. So after you get this bone density scan, so this is your result. So the osteoporosis is defined when this is a T-score, which is compared with younger female. Again, this is defined again for females. So if your score is minus 2.5 or below, the higher the number in the negative is more than 2.5 is your risk of osteoporosis. And then we further defined There is a patients who are severe osteoporosis who have more than minus 2.5. Actually, it's around -3 we consider, but in patients who are minus 2.5 and also have a history of fracture. So the fracture risk, so these are the numbers. So even with patients who have, for example, so the patients who have -1 to 2.5, this is considered an early stage of osteoporosis called osteopenia. Sorry about that. So the low bone mass osteopenia, which is early stage of osteoporosis, so we in these patients who have a higher risk of fracture, we do consider treatment in these patients. So who are these patients? So these patients can have a same T-score, but their fracture risk may be high. I'll tell you how we calculate the fracture risk. We have a tool, it's called FracScore. This is available online. Anybody can put their information in and can calculate the risk. So this predicts your risk of fracturing a bone in the next 10 years. So we'll come to that. So who are the people who are patients who we consider treatment? So based upon the fracture risk, based upon the bone density, and based upon clinical risk factors. So in patients who have a history of hip or vertebral fracture, patients who have a score that's -2.5 or lower, and patients who even are in osteopenia range, which is not osteoporosis, but they have their score is between -1 to 2.5, but they have a higher 10-year fracture risk, which is more than 20%. This is considered major osteoporotic fracture. This is combination of spine, the hip, and the wrist, and more than 3% risk of hip fracture. So this FRAC score is actually calculated when you do that bone density or the DEXA scan. They tell you what is your FRAC score. But anybody who's 65 and above, you can actually calculate your risk. If you have a risk that is exceeding 3% for hip or exceeding 20% for major osteoporotic fracture, you are a candidate to receive treatment. So the clinical risk factors I was talking about, so what are the clinical risk factors? So advanced age, anybody who's more than 65 is considered advanced based upon the guidelines for osteoporosis. Anybody who has a previous fracture, so as I touched base on the fragility fracture, so any fracture that happens with a low impact trauma or from a standing height, that is definitely osteoporotic fracture. There are certain medications, so glucocorticoid therapy, which is also known as prednisone. So people with rheumatoid arthritis or people who have asthma do receive these glucocorticoids for a long time. So anybody who has been on this for greater than 3 months is considered high risk. And patients who are underweight, who weigh less than 58 kilos or 127 pounds, they're at high risk as well because your reserve of bone mass is less. And if you have a family history of osteoporosis or even hip fracture, you are at high risk as well. And history of cigarette smoking, as well as excess alcohol intake. And race and ethnicity also plays a role. So osteoporosis is more prevalent in white adults than blacks, Hispanic, and Asian adults. So it's a serious condition, so it does cost a lot for health industry, as well as it does take a major impact on patient's life. So it causes permanent pain once you have a fracture. You can lose height, your posture is stooped and hunched over. Once you fracture, for example, you fracture your hip, your mobility is limited. So you do feel isolated, and it's not 100% whether you will go back to your normal baseline before fracture. And there is data that people who break their hips can die within 1 year of complications, either related to broken bone or related to surgery for repairing it. And many patients after fracture can require long-term nursing home care. And the cost expenses, so the predicted by 2025, the osteoporosis will be responsible for almost 3 million fractures and 25.3 billion costs annually for treatment as well as nursing home and all those costs. So the treatment options, so there are various treatment options available. Most of them are available for females, but there are some of them FDA-approved treatments for men as well. So I'll start off with the most common treatment we use. The class is called bisphosphonate, and alendronate is the first line of treatment in ideal patients. So it's also called as Fosamax. It's an oral treatment. It's taken once weekly. Most of the time we recommend once weekly. There is abandronate, also called Boniva. So this is a monthly oral treatment. And another is residronate, also known as Actonil. This is also oral treatment, and this is approved for men and women. This you can take weekly, twice monthly, or monthly. And this one, there is an intravenous option available in patients who cannot tolerate oral medication. It's called reclast or zoledronic acid. This is once a year. So the next class of medication, this is called Raloxifene. So also the trade name is called Evista. So this is a treatment which involves modulating the estrogen receptors. So this is considered in females who have a high risk of breast cancer. So this helps to reduce the breast cancer. Many patients who have a strong family history of breast cancer, this may be an ideal option, and it's once daily. And then there is this injection that's called, the class of medication is called rank ligand inhibitor. This is one of the bone receptor inhibitor. So called denosumab or also Prolia. So this is the injection form. It's done every 6 months. So in terms of this slide, these treatment options help to control the bone loss. So they can prevent the bone loss and they can halt the bone loss. So I start with oral therapy first in patients who do not have any gastric problems, no stomach problems, they can tolerate the medication, okay. If they have any stomach problem, acid reflux, any esophageal problems, the oral treatment is not recommended. So intravenous treatment comes next, and this Prolia. So there is a lot of data in improvement of both hip and vertebral, decreasing their risk and increasing bone mass. So this class of medication is called anabolic agent. So these agents actually build up bone. So they build bone. And so the first medication, this is a recently approved, it's called romosozumab or Evenity. So this is an injection form. It's done 2 injections once monthly, and so far it has been tested for 12 months. It is only approved for females. And then there is parathyroid analog, also known as Forteo or teriparatide. So this is an injection. It's a daily injection, and it has been approved in women and men. And then there is a valoparatide, which is also a similar class of parathyroid hormone analog. It's an injection, again daily, but it is approved only for females. So I consider these agents in patients who have, when we discussed about severe osteoporosis, so who have a T-score more than, less than minus 3.2. Questions? Yes?
What are the side effects of the, I know that the oral medications,
Yes.
they stop you from taking them after a certain amount of time
Yes.
because they can give you fractures where you didn't need fractures.
Yes. Yes. So we do the oral treatment. We do consider it for 5 years, and after 5 years, what we call drug holiday. So we take the drug holiday. Now we do monitor bone density or the DEXA scan every 2 years. So once we start the therapy, technically in 5 years, you have 2 bone densities to see if you are actually getting benefits. So if you're not getting benefits, then we change. If you're getting benefits, that's an ideal candidate. So we do take a break after 5 years of oral
Then
therapy.
what happens?
So we monitor bone density every 2 years. So if you start to decline, we have to resume, or we go for a different agent. Yes?
Why do you end up in a nursing home rather than home care? I'm not sure I understand. What can we do better for you?
So it's all dependent upon like how bad the fracture is. So it's just, if you have other comorbidities like blood pressure or diabetes uncontrolled, or you have more complications. So it's all individual basis. Yes?
What are the side effects of that intravenous infusion?
Mm-hmm.
I was told that, it could cause like flu-like symptoms.
Yes,
Is that
yes.
common?
Which one?
Yes.
The last one.
So,
the IV infusion.
Yes, reclast or zoledronic acid, this one. So this one.
Yeah.
Yes. So flu-like symptoms are actually common for this class of medications, but it's seen a little more common with the intravenous because you're getting the whole medication in one day. But it doesn't last more than 48 to 72 hours. So general recommendation is taking Tylenol for two or 3 days, but subsequent infusion or even subsequent doses of oral, it's less risk. Yes.
Okay, with the DEXA tests now, they check your hips and your spine. They do not check the wrist.
Yes.
How do you know if your wrist is
So,
susceptible?
exactly. So it's a great question. So I think it's just the guidelines we went by. So we do check the fracture. If you have a higher fracture risk at the hips or the vertebral column, it will be equal to the wrist as well. So overall bone density. But in patients who have, for example, some spinal procedure, or so in those patients we do exclude the spine and we do check the wrist. Yes.
Can bone regenerate?
So yeah, so that's where these guys are. So they can build up bones, anabolic agents. But the problem with these is, so far we can use them only for 2 years. So we don't have a data beyond that. And once you stop them, you lose them. You lose everything. So we have to use something else. Going back to the first slide. Yeah. Well, we go back to maintain the first slide, the agents. Yes.
I have a lot of patients, seriously,
Yes.
who have dental problems and refuse to take any alendronate or any bisphosphonates, because of that.
Yes.
Could you comment on
Yes.
that?
That is extremely great question. So that's a major concern in patients who have a dental problem or dental concern. So there is a side effect with the first these medications, patients who are on these medication can develop very, very rare side effect. It's less than 0.0001% chance that infection of the jawbone, which is also called osteonecrosis of jaw. So they looked back when this side effect was studied. It was seen in patients, actually cancer patients, who were getting higher doses of this IV reclast or intravenous reclast. And these patients actually had a recent dental procedures. So if we exclude that in patients who did not have a recent dental procedure, the risk was very, very minimal. So what we do in our clinical practice is if you have a dental implant or a dental surgery that is pending, we don't start these treatments. So we ask you to have that done, because once you are on these treatment, the oral therapy can go for as long as 5 years. So we ask them to get that done, and then we start the therapy. Yes.
How long can you stay on Prolia?
So Prolia, so I think we don't have a great guidelines on that, so we're going by 5 years so far. But again, the question is, in 2 years, bone density. So if you have a significant improvement after 2 years of therapy, so we can actually take a break and see. So if you were still, you barely gained any bone, so we continue the therapy. So 5 years so far.
Thank you.
Yes.